Yes, sir. I'm really privileged to introduce our speaker, Dr. Dhalapathy, sir. He is a renowned surgical endocrinologist who did his MBBS from the prestigious Madurai Medical College, followed by MS also, general surgery from Madurai Medical College. He did his MCH endocrine surgery from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Following which he underwent various super specialty courses related with the MCH program. He received international awards from ISSF Travel Agent for WCS 2015 from Bangkok. Followed by he received Best Paper Presentation Award from Asian Association of Endocrine Surgeons, Colombo in the year 2014. He received a Japan Surgical Society Travel Agent Award from Japan in the year 2010. And he received various national and other awards like Best of 2010 from SGPGI Institute, followed by Professor SS Award for Excellence in Research in the year of 2000. ICMR Financial Grant Award for MCH thesis in the year of 2008, and he won Best Paper Award for presentation on study of cardiac dysfunction in hypercatecholaminism and its reversal following pheochromocytoma patients. He is having enormous number of publications to his credits. With this short introduction, we'll go to the topic. Welcome, sir. Welcome to our IMA TNSB Academic CME, sir. Please, you can start the program. Thank you, sir. Thank you very much.
Thank you very much, sir. First of all, I would like to thank the esteemed IMA State President and Secretary as well as Financial Advisors and especially Academic Chairman Ashraf sir for giving me the opportunity to talk a few words about safe thyroid surgery. So in the next 30 to 40 minutes, we will be talking about the basics of, and the nonsense of thyroid surgery and how to go about it in a safe way, where even when it is done by a general surgeon or whoever does it. So if we go to the history, whatever we do, first we need to know about the history. So early attempts at thyroidectomy began in the mid-19th century. So there were so many attempts to do a safe thyroid surgery, but the mortality was to the tune of around 40 to 50%. So in between, they even discarded doing thyroidectomy because of the high mortality, because of the sepsis as well as the hemorrhage. So even in 1866, Samuel Gross had to note that no sensible man will attempt to extirpate a goitrous thyroid gland. Every step he takes will be envisioned with difficulty, and every stroke of his knife will be followed by a torrent of blood. And lucky will it be for him if his victim lives long enough to enable him to finish his horrid butchery. That was the famous statement given by Samuel Gross to not to pursue thyroidectomy in those days. But we have come a long way since then. So where we have a nil mortality or negligible mortality at this point of time due to the advances in science as well as the techniques adopted to do a thyroid surgery. So to give credit to that was Theodor Billroth, who was the modern man who revolutionized not only thyroid surgery, so many surgical disciplines. So at this point of time, the recurrent nerve was around 25%, and he also had a 10.5% mortality. But the modern thyroid surgery owed to Theodor Cocker, who is a Nobel laureate in 1908. He performed thyroidectomy with a mortality of less than 0.2% in 1898. So even after more than 100 years, we are at the same level as Theodor Cocker. This is due to the better hemostats, better antisepsis, all those things which he incorporated in his thyroid surgery. The principles still hold today through what he had envisioned on that day. So to before we proceed to thyroidectomy, we need to know the surgical anatomy and where the thyroid gland basically is situated. This basically because sir told we need to cover for the general practitioners also. So I'll be talking more of basics and then the nonsense of thyroid surgery. So it will be beneath the strap muscles, covered by the strap muscles or ribbon muscle, that is the sternothyroid and sternohyoid over the trachea on both sides. So if we open the strap muscles, this will be the vascular supply as well as the venous drainage for the thyroid gland. The superior thyroid artery and superior thyroid vein will be in the superior pole, and the inferior thyroid artery will come in the lateral aspect. It will not come in the inferior aspect. In the inferior pole, only it will be the inferior thyroid veins. So that will be a major difference between the superior as well as the inferior vasculature. Another thing is the nerves. Nerve, especially we must be very concerned with the external laryngeal nerve as well as the recurrent laryngeal nerve. If you are able to perform a thyroidectomy with preservation of both the external laryngeal nerves and the recurrent laryngeal nerves on both sides, as well as the parathyroids on both sides, then we are doing a very safe thyroid procedure. So as far as the surgical importance is concerned, these are the things which I will be dealing in over the next 20 to 30 minutes. First one will be the external branch of the superior laryngeal nerve. Next will be the recurrent laryngeal nerve. Then we will talk about parathyroids, the ligament of Berry, and then the embryological remnants. Embryological remnants in the term, it means the tubercle of Zucker candle, pyramidal lobe, as well as the thyrothymic thyroidras. So there are various indications for thyroidectomy, and the most common one would be a thyroid malignancy, and next would be a toxic multinodular goiter, or with any compressive symptoms with a thyroid enlargement or refractory Graves' disease, all those things. So before we proceed for a surgery, we must first establish the disease status. First one to be done is a thyroid function test in the form of TSH. TSH is more than sufficient in the initial evaluation of any thyroid nodule or a thyroid gland enlargement. So if the TSH is normal, then we would like to do a ultrasonography or high resolution ultrasonography of the neck, which will give the features of the thyroid nodule as well as the characteristics of the nodule, and also gives features anything that is suspicious for malignancy in an ultrasound. Even the FNAC can go wrong in few centers or few places, but a good sonologist or a surgeon or a physician performed ultrasound will go a long way in detecting the suspicious features of malignancy on ultrasound. So ultrasound is very, very important, and we do not require a computerized tomography or MRI or a highly sophisticated images to detect malignancy in case of a thyroid nodule or a thyroid enlargement. So next one will be a fine needle aspiration cytology. So after thyroid function test, high resolution ultrasonography, and then fine needle aspiration. All these three form the triad or triple examination of a thyroid nodule. Then the laryngeal examination is not a mandatory one. It is basically for a medical legal purpose. If there is any voice change or suspected vocal cord palsy and other comorbidities, we need to examine. So if there are clinically significant nodal disease, then we need to have an imaging of the nodes and the FNAC of these nodes. And these nodes can also, if that is benign in the FNAC, then we can do a frozen study during the surgical procedure itself. So we need to know about any cervical spine disease or cervical spondylosis, because the positioning of the patient with an extended neck position might compromise the spinal thing. So we need to be very careful while taking the patient for a surgery. We need to ask the patient about any spine disease in the neck. And we need to exclude pheochromocytoma if it's a suspected medullary thyroid cancer, because it can coexist with the medullary thyroid cancer in case of a MEN2A and MEN2B patients. And informed consent is a must as in all cases. So based on the FNAC report, as we know, we have 6 categories. This is the Bethesda category, and the risk of malignancy based on the Bethesda category. If it is non-diagnostic, it will be around 5% to 10%. The non-diagnostic category must be less than 5% in a good FNAC center or a pathologist, so that the yield must be more. Always it is better to do a ultrasound guided FNAC rather than a blind FNAC, so that we know where we are hitting the target, and the yield as well as the cellularity will be better in that case. Next one will be a benign one, and then the previously it was classified as a follicular neoplasm. So now it is categorized into 3 categories: ATP of undetermined significance, follicular neoplasm, and suspicious of malignancy. And the last one will be a malignant one. So this is the ideal positioning of the patient, where the head must be supported well with a gel or a support. Then hyperextension must be avoided, so that it must not cause post-operative pain, not during the after surgery. So patient is cervical spine disease, we need to place them in a minimal or no extension. That is very important during a thyroid procedure or to perform a safe procedure. So the critical steps during thyroid dissection is always we prefer a transverse skin crease incision rather than putting a new incision. Always we try to place the incision in the skin crease, even if it is little high or low. Better to select the lowest skin crease, so that after surgery, post surgery, the scar is not visible, or the scar merges with the skin crease. So next thing will be a subplatysmal flap. Raising a subplatysmal flap is very important, both superiorly as well as inferiorly, because that is the avascular zone and there will not be any bleeding at all. So if we need to have a bloodless surgery or bloodless field, the raising of flap is very important in this subplatysmal flap. Next one, after raising the flaps, we can go by both ways, either open in the midline between the sternothyroid muscles, and then we can access and we can divide the sternothyroid muscle and keep the sternohyoid muscle, and ligating the middle thyroid vein, which will be present in 50% of the thyroidectomy specimens. Not all patients or not all thyroid specimens will be having a middle thyroid vein, 50% will have. So we need to identify that before we mobilize the thyroid gland. So we need to ligate and divide the middle thyroid vein, and then in the superior thyroid pole, we need to identify the external branch of the superior laryngeal nerve, which we will be talking later, and the superior pedicule has to be addressed. Then identification of the rectal laryngeal nerve and removal of all visible thyroid tissue. That is the definition of a total thyroidectomy. Total thyroidectomy, in the true sense, is removal of all macroscopic thyroid tissue. Is the definition. So that I will come into it. What is removal of all thyroid tissue? So then identification of parathyroid glands. This is very, very important. Rather than preserving the nerve, identification and safeguarding the parathyroid glands is of utmost important, because the hypoparathyroidism or the permanent hypocalcemia is devastating for the patients, as well as it will hamper their occupation also. Prior to closure, we must have a dry bloodless field before we start closing the wound. And so first we will talk about the rectal laryngeal nerve. Rectal laryngeal nerve, always previously there were thoughts that we need not see the rectal laryngeal nerve. These were all very old concepts. The current trend, or the trend that has been followed for quite 2 to 3 decades, it's always better to see the nerve. So we have to identify the nerve, and previously we need to chase and see the nerve. Now it's not that. We need to encounter the nerve. That is, while you proceed and perform the thyroidectomy, we will encounter the nerve at its place. So we need not chase the nerve as previously, but we will definitely encounter the nerve during the procedure. If it is not there, then we have to identify and preserve it. The rectal laryngeal nerve should be identified and has to be preserved, because this can cause if unilateral any injury or traction or thermal injury, it will cause a hoarseness of voice, and it can cause litigation also in the post-thyroid phase. So the the rectal engine nerve, if we see the right side nerve, it winds around the right subclavian artery, and then it ascends through the tracheoesophageal groove. In the left side, it winds around the aorta and reaches the laryngeal entry point in the tracheoesophageal groove. So the right side as well as the left side, there is vast difference between its course. So we need to be prepared for that, and we need to be well versed in the anatomy of the rectal engine nerve. So the rectal engine nerve is intimately related to the ligament of Berry in its laryngeal entry point. So that is the most common place where we can injure the rectal engine nerve, because sometimes we will take a bite to have hemostasis of the vessel that is in the Berry's ligament, or use energy sources like cautery, monopolar or bipolar or harmonic to ligate the ligament of Berry. That can cause injury to the rectal engine nerve. So we have to be very careful in dealing with the ligament of Berry. Moreover, there is branching of rectal engine nerve. As we say that rectal engine nerve, it's not a single one. It gives away so many branches before it reaches the laryngeal entry point. So we have to be careful of these branches. I will show the branches. What are the branches the rectal engine nerve goes before it enters the laryngeal entry point. So in a good center or a place, the rectal engine nerve or injury or the vocal cord dysfunction following thyroidectomy has to be permanent, has to be less than 1 or 2%. That is the less than 1% is the what accepted one. So again, this is the course of the rectal engine nerve in a plane where we can see the right side courses around the right subclavian artery, left side around the aorta. The rectal engine nerve has two branches. That anterior rectal engine nerve and posterior rectal engine nerve. Sometimes it can have, sometimes it's a single branch, single trunk and many branches. Another thing is it can have two main trunk, and sometimes it can have 3 branches also. So previously the concept was the anterior one innervates the cricoretinoid and thyroid and all laryngeal interstices and contribute to the Gallant's anastomosis. And posterior one contributes to the PCA, that is the posterior cricoretinoid. Now it's not like that. As the rectal engine nerve reaches close to the laryngeal entry point, it has more of a motor component. Previously it's a mixed nerve basically. So as it reaches the laryngeal entry point, it becomes more of a motor. It has more of motor component than a sensory component. So this is the relationship between the inferior thyroid artery. As I told, the inferior thyroid artery comes not at the inferior pole of the thyroid gland. It comes lateral to the thyroid gland and gives blood supply to the thyroid gland. So you can see the rectal engine nerve can be either anterior to the inferior thyroid artery, or it can be posterior to the inferior thyroid artery. It can even go between the branches of the inferior thyroid artery. Another thing is we must not ligate the inferior thyroid artery at its trunk here or here, because the parathyroid blood supply, the end arterioles, the arteries that supplies the parathyroid comes from the inferior thyroid artery. 90% of the parathyroid blood supply, both the superior as well as the inferior, is from the inferior thyroid artery. So we need to ligate the inferior thyroid artery after it gives branches to the parathyroids, not at its trunk. It's easy to ligate the inferior thyroid artery at its trunk so that you stop all the blood supply. In that way, what happens is the parathyroids will be preserving, but the thing is, we will be compromising the vascularity to the parathyroids also. So we must not ligate the inferior thyroid artery at its trunk, and rather than it after it gives at its terminal branches only we need to ligate. So I will show those things in the later pictures. So the rectal engine nerve, as I said, it can be approached by various ways. Most common is the lateral approach. That is the most common one where we follow. Suppose if it is a huge retrosternal guider, it is not easy to approach on the lateral side. Then in that case, we'll approach by a superior approach. And if it's a reoperative surgery, then we will try to approach from the inferior approach. So it depends on what type of case we are doing, what type of pathology we are dealing, whether it's a virgin surgery or a recurrent surgery. So all those things has to be, and we need to customize as per the patient on per the case on that day. So as I said, this is the trachea. You can see from the lateral view, this is the recurrent laryngeal nerve. It goes. This is the laryngeal entry point. You can see so many branches. It gives branches to the trachea. It gives branches to the esophagus. It gives branches to the ganglion. And all those branches, it keeps on giving before it reaches the laryngeal entry point. So only if these things are compromised, what happens, even if we have not operated on the esophagus, these branches which supplies the esophagus, if it compromised, so can have the patient will have difficulty in swallowing even post thyroidectomy. So as I said, here you can see there are the two branches of the recurrent laryngeal nerve. This is the anterior branch and this is the posterior branch. So we have to be very careful in isolating the recurrent laryngeal nerve and preserving it in its entirety. So you can identify the recurrent laryngeal nerve with a vasa vasorum. Actually, a red color streak of blood vessel will be over passing on the nerve. So that is an easier way if you have any doubt in identifying the recurrent laryngeal nerve also. So here you can see there are 3 branches of the recurrent laryngeal nerve. This can occur in around 5 to 7% of total thyroidectomy cases. So as I told, this is the ligament of Berry. So this is the place where we need to be very careful. We must not use cautery or any energy source to bust this ligament of Berry. It is basically a condensation of the deep cervical fascia, attachment of the thyroid gland to the trachea. So in this place, there is a small twig of arterial twig will be there in the ligament of Berry. So if we are surgeons who are in this, you would have experienced that. If you are not tying this ligament of Berry properly, then sometimes there will be a sudden rush of arterial twig bleeding will be there. That can compromise or it can have an effect on the recurrent laryngeal nerve when we try to hold the bleeding in the laryngeal entry point. So we have to be very careful while leading with the ligament of Berry, and ideally it has to be with on a needle bite. We have to tie the ligament of Berry, and always do not use any energy source near the recurrent laryngeal nerve. So next is, as I told, the recurrent laryngeal nerve injury can be not, though we would have preserved on both sides with its entirety, still you must not have give any traction to the nerve. Even the traction to the recurrent laryngeal nerve can cause neuropraxia and cause temporary palsy. So that also has to be avoided. At the recurrent laryngeal nerve, we must treat it with utmost respect, and we need to be very cautious in dealing with the nerve and not to unnecessarily poke the nerve or give traction to the nerve or use energy sources near the nerve. So if you are using any clip or compression, we must be very careful that we are not taking any branch or the recurrent laryngeal nerve in the clip. So for that, we need to have a thorough anatomy of the normal anatomy as well as the variant of the variants of the recurrent laryngeal nerve, and we have to be under constant view during our surgery in every part of dissection to prevent injury to the recurrent laryngeal nerve, because we know that if both the nerves are damaged, then the patient would have to be for a permanent tracheostomy also. So we have to be very careful in this. So what happens is, over the period we have evolved it to use intraoperative nerve monitoring to have a safe thyroid procedure. This has been followed for the more than 15 years, where we use this specially devised endotracheal tube, where we have this monitor will be there. We have an electrode, and if we can have the functionality of the nerve as well as the intactness of the nerve, both pre-surgery as well as post-surgery, which can be ascertained by this interop nerve monitoring. Many of the centers are having this interop nerve monitoring, and it is a better tool. So to avoid medical legal litigations, as well as to safeguard us, as well as for the welfare of the patients. So this is one case where you can see, and this is the trachea. You can see on the right side. This is the non-recurrent laryngeal nerve. As I previously was talking about recurrent laryngeal nerve, where it winds around the subclavian artery and enters into the through the tracheoesophageal groove. Here, it comes directly from the vagus, and you can see the thyroid gland here. This is the trachea. So this is the carotid artery. The vagus will be here within the carotid sheath. So it comes transversely across from the vagus and enters into the laryngeal entry point. So this will be more, majority of the non-recurrent laryngeal nerve will be on the right side only. If the left side, it will not be there, because the recurrent laryngeal nerve on the left side, it winds around the aorta. Suppose if there is a non-recurrent nerve on the left side, then the patient must be having a situs inversus. So this, as I told, this is the normal recurrent laryngeal nerve which goes, and the non-recurrent nerve comes just like that, which I have shown in the previous picture. So the prevalence is actually right side, as I told, 0.3 to 1%. As of now, we have around 24 cases. We had an experience of around 24 to 25 cases of non-recurrent laryngeal nerve during our thyroid surgeries. So mostly these non-recurrent nerve will be associated with the vascular anomaly, that is arterial lusoria will be there on the right side. So many people do a routine CT scan to see any aberrant vascular anomaly is there on the right side. If it is there, then they will suspect a non-recurrent nerve on the right side and be careful during the thyroid procedure. That is one way of anticipating a non-recurrent laryngeal nerve. So we had published this also, the non-recurrent laryngeal nerve, this. So next one will be a EBSLN, that's the external branch of the superior laryngeal nerve. It is otherwise called Singer's nerve, because it supplies the cricothyroid muscle. Anything that is damaging the cricothyroid or the external branch of the superior laryngeal nerve causes loss of pitch of the voice. So singers, all these things, they will not be able to raise their pitch. And the thing is, when there's injury or ligation of the external branch of the superior laryngeal nerve, what happens is their voice huskiness and the fatigue will be there. So we have to be very careful, especially professional singers, and not only professional singers, all people will want to have a normal voice. So we have to be careful in dealing with this external branch of superior laryngeal nerve. And 80% of the cases, it can be visualized. So the 100% now, what they do is we use a nerve monitoring, as I showed there, to show the intactness of the external branch of the superior laryngeal nerve. Why I am saying 80% of the cases is, if it is a grade 1, type 1 of nerve, it will be more than what we visualize. So it will be very high. So if you are not able to see up to 1 centimeter or more than 1.5 centimeter from the superior thyroid pole, then it will be very much higher, and we need not chase to see that also. So as I said, any dysfunction of this nerve will cause a lowered voice projection, lowered voice fundamental frequency, fatigue, and inability to achieve high frequency sound. This happened in a opera singer in Italy. Then only the people came to know about this nerve, and because she was a very famous opera singer, and she had a surgery and had an injury to the external branch of the superior laryngeal nerve. So we can classify this external branch of superior laryngeal nerve with the superior thyroid pole as 3 types, where type 1 is more than 1 centimeter from the superior thyroid pole. If it is more than 1 centimeter, then the probability of having an injury or ligation of the external branch of superior laryngeal nerve is very, very less. So it will escape injury. But the thing is, in type 2A and 2B, where it is very closely associated to the superior thyroid pedicle, these two are the ones which are prone for injury. So the ideal way is to see the nerve and then ligate the vessels, the superior thyroid vessels individually. That is, skeletonize these vessels and tie each the anterior branch, posterior branch of the superior thyroid artery individually and the superior thyroid vein individually, so that the nerve will not be trapped in the mass ligature. So mass ligature is better avoided in the superior thyroid pedicle. So next is that transection of the sternothyroid muscle also increase the exposure of the superior thyroid. Usually we transect all the sternothyroid muscle in all our thyroidectomy specimen. It depends on the individual or the surgeon's preference also, but it gives good leverage as well as the good exposure to the thyroid gland. So as I told, this is the superior pole, and you can see the this is the medial thyroid space. That is where you try to see the external branch of the superior laryngeal nerve. So this is the cricothyroid muscle. This is the place where you. This is the external branch of the superior laryngeal nerve. So here you can see. So we tie below the nerve so that we preserve the nerve. So here you can see this is the type 1 nerve. So here also you can see the external branch of the superior laryngeal nerve. This is a type 2A that is very closely associated with the superior thyroid pedicle. So next one will be we'll talk about the embryological remnants. Embryological remnants is one where it will be there in around 50% of all thyroidectomy specimens. All these embryological remnants are very important to be removed for a safe thyroid procedure, because if we are leaving these embryological remnants, what happens is if we are dealing with a toxic goiter or in case of a thyroid malignancy, so we are leaving a thyroid remnant. So we will not be achieving a total thyroidectomy at all. That means post-operatively, we will not be able to give radioiodine or iodine-131 therapy for these patients where thyroid malignancy has been diagnosed, because the minimum thing what we need is a total thyroidectomy, because the radioiodine we are giving in the post-operative period for these thyroid malignancy or differentiated thyroid cancer patients will go to only to the thyroid remnant which has been there and not to the metastatic sites. So to achieve this, we need to address these embryological remnants for a safe and complete dissection. So among those, the major one is the pyramidal lobe. This pyramidal lobe is the one which will be in the isthmus, just above the isthmus, and it will be present in at least 50% of all thyroidectomy specimens. So especially in case of toxic goiter, Graves and all, it will be very much enlarged and it will be going above also. So we need to remove the whole of this pyramidal lobe along the thyroid lobes. So next one will be the tubercle of Zucker candle. Tubercle of Zucker candle will also be present in 50% of all thyroidectomy specimens. So there are various grades in the tubercle of Zucker candles also, depending on the size of the tubercle of Zucker candle. So this usually will be most often course the rectal nerve is the tubercle of Zucker candle is a pointer towards the rectal nerve. Suppose we are trying to see the rectal nerve, this tubercle of Zucker candle will help in identifying the rectal nerve, because it is said it is a pointer towards the nerve. So this can also be taken as a tip to identify the rectal nerve. So as I said, there are 3 grades in it, which is based on the size of the tubercle of Zucker candle. So you can see this on tubercle of Zucker candle. Here you can see the nerve. Here the tubercle of Zucker candle. Here you can see the nerve. So as I said, this is of a surgical significance to remove this tubercle of Zucker candle. And moreover, the superior parathyroid gland will be very close to the tubercle of Zucker candle in some cases also. During our experience, we had a giant tubercle of Zucker candle. See, you can see previously it was thought as a retrosternal goiter from the lower part of the thyroid gland, but intraoperatively we could find it is a tubercle of Zucker candle which was going retrosternally. So this is one of a rare case where it's more than 5 centimeters of a tubercle of Zucker candle is labeled as a giant tubercle of Zucker candle, and we encountered it also. So next one will be a thyrothymic thyroid rest. This is one entity which is ignored or which is not given much importance. Basically, majority of the retrosternal goiter or the which are diagnosed as retrosternal goiters are thyrothymic thyroiditis are not a true retrosternal extension of the thyroid lobe or thyroid extension. So in this, there are 4 grades in it. That grade 1 will be this attached to the thyroid gland. And grade 2 will be a narrow pedicle, it will be attached. In grade 3, it will be a fibrovascular band. And grade 4 is separate, completely separate. These embryological remnants, grade 3 and grade 4, they enlarge and they become the huge retrosternal goiters over a period of time or during the course. So these grade 3 and grade 4 are the one which constitute the majority of retrosternal goiters in surgical practice. So you can see this is one of a thyrothymic thyroiditis with a retrosternal extension. So you can see this is also a thyrothymic thyroiditis. You can see the gland is separate. It was a retrosternal one, which we need to remove it, and it was a grade 4 thyrothymic thyroiditis. Just giving 1 or 2 pictures so that it be of useful to it. So this is another thing where you can have a separated this entity called a grade 4 thyrothymic thyroiditis. So this is another one. This is a grade 3 one where you attached with the fibrous tissue. So this is again separate from the thyroid gland. These are all retrosternal components, which might be missed if you are not seeing it properly during surgery or preoperatively also. So this is another one. This is one where you can have all the 3 embryological remnants. This is the pyramidal lobe. This is the tubercle of Zucker-Candle, and this is the thyrothymic thyroiditis. So we had our publication on this long back of around 1,118 total thyroidectomies and the implications of these embryological remnants. And so retrosternal goiter, as I will touch upon it. Majority, that is more than 90 to 95% can be delivered through the neck, even if it reach near the aorta or beyond the aorta also. The only thing that which will hamper in delivering is the thoracic inlet diameter in relation to the retrosternal component. If the retrosternal component width is more than the thoracic inlet, then we will find it difficult to remove through the cervical approach or through the neck. Otherwise, 90 to 95% of these retrosternal goiters can be easily delivered through the neck itself. If it's going into the posterior mediastinum, sometimes we might require a posterolateral thoracotomy also. So coming on to the parathyroid glands and preservation of parathyroid glands, as we know, the number of parathyroid glands is not a constant one. Only 4 parathyroid glands will be present in around 80 to 85%. So there can be numerous parathyroid glands. Some might have 3, 5 parathyroid glands will be there in around 10 to 20% of population. So we need to be careful in identifying these parathyroids as well as preserving these parathyroids during surgery. The general rule is the superior parathyroid will be posterior to the rectolaryngeal nerve and the inferior parathyroids will be anterior to the rectolaryngeal nerve. As I said, we must not tie the inferior thyroid artery at its trunk, and we need to tie in this area after it supplies the parathyroids, after the parathyroid blood supply. So as I told, it is inconstant. The superior parathyroids will be little more constant compared to the inferior parathyroids. Inferior parathyroids will be either in the lower pole of the thyroid gland, anterior to the nerve, or in the thyrothymic ligament, or in the thymic tissue. So there are various ways to identify these parathyroid glands compared, because if a lymph node can confuse or a thyroid tissue can confuse us with the parathyroid gland, or a thymic tissue can confuse us, a fat can confuse us with the parathyroid gland. So we need various, there are various things that can help in identifying this, whether the structure what we are dealing is a parathyroid gland or not. So among the most important will be the, it will be soft and it will move within its capsule, and that you can location is very important, as well as it will move within its capsule, and it has a arterial supply, which is a end arteriolar supply. So if you are doing a total thyroidectomy and still a parathyroid gland has been found in the thyroid tissue, then that parathyroid tissue has to be auto-transplanted so that the parathyroid auto-transplanted tissue will function in 4 weeks' time. So some centers or even what we do is, out of the 4 parathyroids, we pick up one parathyroid, do a mincing and do a prophylactic auto-transplantation in the sternocleidomastoid muscle so that the permanent hypocalcemia is prevented. That is very important. As I told, getting cramps in the post-operative period, that is a permanent hypocalcemia, is very much disgusting or very much annoying to the patient. So we need to prevent permanent hypocalcemia to all thyroidectomy cases. So we need to auto-transplant one of the parathyroid in the sternocleidomastoid even as a prophylactic thing. So you can see the parathyroid, the superior parathyroid. As I told, this is the superior parathyroid, posterior to the nerve, and this is the inferior parathyroid. See here, you can see the superior parathyroid. We have to see the parathyroid after surgery also to see the color of the parathyroid. If there is any venous congestion is there, then we have to do a knife test. That is, we need to open the capsule so that the venous congestion is relieved. Otherwise, not only preserving the parathyroid will ensure its functionality. The thing is, we need to ensure it is functioning parathyroid. That is very important rather than anatomically preserving a parathyroid. So here, this parathyroid. So this is the nerve, and this is the superior parathyroid, and this is the inferior parathyroid here. So this one. So to identify these parathyroid, there are various gadgets or adjuncts that are available. That is, one is the NRF based system, that is the ICG, that is indigo carmine, and we use the intraoperative autofluorescence as well as indocyanine green angiography for the reduction and preservation of parathyroid. Whatever these adjuncts are there, main thing is the surgical expertise to identify and preserve these parathyroids. And then these adjuncts will help in establishing or reconfirming our diagnosis or reconfirming that we have preserved these parathyroids. So these are the NIRF and indigo carmine to see whether the parathyroid what we have preserved is vascularized or devascularized. If it is devascularized, what we need to do is take it out and do a auto-transplantation in the sternocleidomastoid muscle. So another is thing is we do a sutureless total thyroidectomy now for majority of the cases. We don't use any suture material. So we use this harmonic scalpel from the beginning to the end so that it saves time, and also better hemostasis will be there. Compared to complications in cut and tie as well as this sutureless thyroidectomy, there is no difference in the complications, but we have a better operating time as well as lesser blood loss. So the field must be bone dry post-surgery. That is, the field must be bone dry. It is not mandatory to place a drain post-surgery. It depends on the surgeon preference. But the thing is, we need to do a Valsalva maneuver post-surgery and see there is no bleeding or any ooze in the surgical field after giving a Valsalva maneuver, so that even anything that has closed venous or arterial spasm might give way and show that there is any bleeding or not. So post-surgery, it has to be bone dry before we close the surgical field. So you can see that. So before I finish, I will say that understanding the anatomy. Previously, it was anatomy-based thyroid surgery. It has now evolved into embryology-based thyroid surgery. So we take care of all these embryological remnants, the nerves, parathyroids, and we must have good expertise in dealing these nerves and parathyroids to have a safe thyroid procedure. And we have to be very precise in surgical dissection. We must not be blunt. We must always use sharp instruments during our dissection and minimize the surgical complications. And we must not be surprised to see any abnormality during our surgical procedures. We must be prepared to do that. So the extirpation of the thyroid gland typifies perhaps better than any other operation. The surgical triumph of the surgeon's art. We need to be given credit to Halstead, who has told this in 1920 about thyroid surgery. Even now, it holds today true. Thank you very much for the opportunity. Again, I thank the IMA chairperson, scientific chairperson, as well as the president, secretary, as well as all other office bearers for the wonderful opportunity. Thank you very much, sir. I'll be happy to take any questions if it's there.
Thank you, Dhalapathy. Thank you so much. Most of us may not be aware of all these problems in the surgery, know how challenging it is. I think the doctors who are joined, doctors, I welcome you to ask some questions, interact with one of the top endocrine surgeons, sir. Please.
Yes, sir.
I'll be happy if one of the youngsters who are seen become an endocrine surgeon at a later date, motivated by his lecture. Arul, please take up the questions.
Yes, sir. Yes, sir. Thank you, sir. Thanks a lot for a extensive discussion as well as a presentation on safe thyroid surgery, sir. Shall we start questions, sir?
Yes, sir, please.
Yes, sir. 1 minute, sir. I got a few questions from chat box as well as through WhatsApp, sir. We'll have discussion. Yes, sir. So what is the role of anti-thyroid drugs? I don't know. I'm not able to get the exact question. First question, sir. Post-operative thyroid crisis, how to manage it?
Thyroid crisis, which situations, whether it's a surgical crisis or a medical crisis, what if you are talking about thyroid storm? If the question is regarding thyroid storm, means nowadays thyroid storm must not happen. We do not take the patient for surgery unless otherwise the patient is euthyroid. So when the patient is euthyroid, if we are dealing with a Graves' disease or a toxic multinodular goiter, unless otherwise the patient is euthyroid, we will not take up the patient. So there is no question of thyroid storm at all, and I have never seen a thyroid storm in these 20-25 years of surgical.
Yes, sir. The message to participant is before taking the patient, we have to make the patient euthyroid, and then only we have to take that case. Am I right, sir?
Yes, sir.
Yes, sir. Thank you, sir. Next question is how incidence of recurrent laryngeal nerve during surgery, sir?
Injury, sir?
Yes, sir. Recurrent laryngeal nerve.
The incidence.
That's what I was telling, sir. In a good center or a high volume thyroid surgeon, the incidence has to be less than 1% or less than 0.5%, sir.
Yes, sir.
There can be temporary paresis can be there. As I told, I was talking, if there is stretching of the nerve or use of any energy sources close to the nerve, even though the harmonic what we use, they say only 7 millimeter spread is there. Still, if we use more than 2 centimeter, also there can be some thermal spread can be there, or stretching of the nerve can cause paresis. These will be shown as a temporary paresis in the post-operative period, but they will recover. These temporary paresis will recover in 3 to 6 months time at the most. So when we are talking about permanent palsy, it has to be 1% or less than 0.5%. Especially these can be attributed to in case of malignancies where we do central compartment lymph node dissection, where the nerve will be cruising in the lymph node area. So where we need to stretch the nerve or need to handle those nerves. In those cases, temporary palsies can occur. But the thing is, we have to be as minimal as when we are handling the recurrent laryngeal nerve during our surgical procedure, and to have minimal interaction with the nerve. But we need to always have or visualize the nerve during the entire procedure.
Yes, sir. Yes, sir. So another question is how common ectopic thyroid gland happens, and is it possible to diagnose by nuclear thyroid scanning?
Actually, nuclear thyroid scan is obsolete now. It is not required or it's not needed in the preoperative setting at all. That was maybe 2-3 decades back only nuclear scintigraphy has been done to see the functionality of the gland, or because after the advent of ultrasonography as well as CT scan, the nuclear imaging doesn't hold any relevance at all. The nuclear scan or nuclear medicine role is there on majority in the post thyroidectomy, especially when we need a radioiodine therapy in the form of iodine 131. The only indication for nuclear scan in the preoperative setting is to suppose still there is a dilemma whether what we are dealing is a thyroiditis in a toxic phase or a Graves' disease. Then this nuclear scan, technetium, that too not a radioiodine scan, technetium 99 scintigraphy is more useful. That will tell whether what we are dealing is a thyroiditis case or a Graves' disease patient. That is the only indication in the preoperative setting. But other thing, there is no role of any nuclear imaging in the preoperative setting for in the evaluation of a thyroid nodule or a thyroid gland enlargement or thyroid pathology.
Yes, sir. Thank you, sir. Another question is how to manage post-operative hypocalcemia in the.
That's what post-operative, actually hypocalcemia in the post-operative phase, you have to divide it into a temporary or a transient hypocalcemia. Another is a permanent hypocalcemia. Transient or a temporary hypocalcemia can occur in around 20 to 40% of total thyroidectomy cases. That is acceptable. But the thing is whether it will go into a permanent one that can, or it will be remain temporary. That if we do a PTH assay in the post-operative period, immediately after surgery or 6 hours after surgery, if we do a PTH assay, if PTH is in the normal range, then or more than 10 picogram per ml, then we are 100% assured that the functionality of the parathyroid will be there. The thing is, if the patient is having temporary hypocalcemia, we need to assess whether the only clinical signs are there or both signs and symptoms are there, or the patient is having severe cramps, or we have to grade these hypocalcemia symptoms. In grade 1 or very minimal symptoms, that is only tingling sensation in the fingers, toes, and then we can manage this with the oral calcium as well as vitamin D. Oral calcium per day, we can give up to 2 grams of elemental calcium per day. That is the maximum dose we can give. We can give calcium carbonate in the form of shell cal. All these things are calcium carbonate, which has a better absorption than calcium citrate. Calcium citrate has a lesser absorptive capacity than calcium carbonate. But the thing is, citrate will be present in only 21% of elemental calcium will be there, or absorbable calcium. Here, calcium carbonate 40% will be there. So we need to know what type of calcium salt we are giving for treating hypocalcemia post-operatively. Another thing is, rather than giving more of calcium, we have to give 125 dihydroxy vitamin D3, that is called active vitamin D or calcitriol, along with vitamin D. That is very, very important while treating post-operative hypocalcemia, because the absorption of calcium, there is 2 ways the calcium is absorbed. One is by the active absorption as well as the passive absorption. Passive absorption will be there, which cannot be modified. But the active absorption, we can increase the absorption of calcium more than 30 times if we give active vitamin D in the jejunum as well as the ileum. So if we are treating post-operatively, we have to give oral calcium along with active vitamin D, not cholecalciferol, because the cholecalciferol is an inactive vitamin D, that is 25 hydroxy vitamin D. We have to give 125 dihydroxy vitamin D3, that is calcitriol. This is orally in a divided doses. The half-life is around 5 to 8 hours, this calcitriol. So you can give even in a TDS dose or a BD dose. Calcium can be given in a oral calcium, maximum 1 day, you can give 2 grams of elemental calcium. But for treating the symptoms, we need to give IV bolus of calcium. That is slow IV, we need to give 1 or 2 ampoules of calcium gluconate we can give. That too, while we are giving, we have to check the pulse, and cardiac monitoring has to be there, or we have to check the pulse. Slow IV over a period of 5 to 10 minutes has to be given. And then once the symptoms or cramps subside, then we have to start infusion of calcium to the tune of 1 to 2 milligram per kg per hour over 24 hours. So it has to be titrated every 6 hours, the calcium, IV calcium, And meantime, while we are giving IV calcium, we have to supplement with oral calcium as well as active vitamin D3 and then gradually taper it off once the patient, depending on the patient's symptoms and signs.
Yes, sir. Thank you, sir. Is there any role of steroids to deal with nerve injury cases?
The best thing to preserve or have the functionality of nerve is to prevent nerve injury. There is no new thing that they can treat the nerve injury. Even if we transect it and find it, we can even suture it with the 80-proline. But the thing is, nobody knows whether what we are suturing is going to be functional or not. Steroid, it's a controversial thing. It might not have a much role in the functionality of the injured nerve in the post-operative period. When there's a traction, yes, there can be some improvement can be there, but it all depends on whether the intactness of the nerve is there or not.
Yes, sir. Thank you, sir. Thank you, sir. Shall we take 2 questions from audience directly, sir?
Yes, sir.
Please.
Yes, sir. Dear participants.
One question, Dr. Dhalapathy.
Yes,
Here
sir.
we have got a lot of developments like robotic, laparoscopic, and so
Yes,
many.
sir, yes,
Is there anything like new development as a student you must have seen now last 25 years? Is there any new development
Yes,
to
sir, yes,
prevent
sir.
these complications?
Yes, sir. Actually, nowadays, because it was as you told you, most of many general practitioners, I didn't touch about the newer nonsense of surgery, where we do all these robotic surgeries or transoral surgeries. Nowadays, we do transoral thyroidectomies. Through a robotic transoral thyroidectomies, we approach the thyroid gland through the breast approach or the axillary approach. All these things are neurodevelopments. With the advancement of energy sources and the instruments we have, those have all this. Though we say it's a minimally invasive surgery, with these robotic surgeries or axillary or a breast approach, axillary breast approach or a transfer, it's not a natural cavity, just like an abdomen, where we have a natural cavity where we can do a laparoscopic procedure or a robotic procedure. Here, we create an artificial plane, sir. So it is not a natural plane. So the thing is, the scar will be avoided in the neck. That is the only advantage. Other than that, there are quite a number of complications, and there will be, because we are creating an artificial plane through the axilla or breast or the transoral approach. The morbidity is higher than in an open procedure. That's what the thing is. We can avoid a long-term scar. As Indians, we have a good skin crease where over a 3 to 6 months time, most of the patients, when they come to our OPD, again, we will ask them whether we have performed surgery to you or not, because we will not be able to differentiate whether the patient has undergone a surgery or not at all, because we will not be able to find the scar at all. That is the thing. But still, we need to know these neuro advancement, and we do these procedures, but as a selective cases, it cannot be applied to a majority of the patients. That is the thing.
Thank you, sir.
Thank you.
Dear participants, if you have any questions, you can ask to speaker directly. You can unmute yourself and you can ask if you have any questions. We can take 1 or 2 questions and we can close the session.
Dr. Sridhar has joined, or Dr. Gauri Shankar
Illing, sir. Sir join Panling, sir.
I think we'll finish it off, Dr.
Yes, sir. Thank you, sir. Dhalapathy, sir, thanks a lot for accepting our invitation. Really, we enjoyed your vibrant presentation. And thanks a lot again for good discussion on the topic also. Most of our general physicians and our regular participants benefited from this one, sir. With your permission, we will release a YouTube channel after your approval. We will send a link to you, sir.
Thank you very much, sir. Thank you, Ashraf, sir.
Dhalapathy, எங்களுக்கு ஒரு article மட்டும் வேணும் book போடும்போது, please. Okay, we will get an article for what you spoke. Thank you, ma.
Okay, sir. Thank you very much, sir.
God bless. Take care.
Seniors and friends. Thank you.
Take care, all the delegates. Our prayers to all the delegates who have joined. Youngsters, we wish you a very good future. Okay.
Ashraf, sir, participants got a small message, sir. On behalf of IMA TNSB Academic Committee, we like to inform you, since we took office in the month of January 2024, we conducted more than 9 CME programs. All the programs, all the programs, participants received TNMC approved certificates individually. For the last 3 programs alone, we are waiting for TNMC approval for you to receive certificates in your portal. This is one point. The maximum participants participated in our event is 850 in the month of January 2024. After that, we are having average participation of around 500 unique participants in our event. And another thing is, please type your name, TNMC number, email ID in the Zoom chat box, because TNMC observer will consider that as an attendance for you to give. They will take that as an attendance to give TNMC approval certificates for individual participants. That's one thing. We noticed the participants are not typing your name properly in the Zoom chat box as well as in the Google link. Please type properly as mentioned in your TNMC certificates which you are having with you. With this, we are closing the session. If you have any doubt, feel free to contact me. My number is 8586894306. Dr.V.Aruljothi, convener from IMA TNSB Academic Committee. Thank you. Thank you very much.
Aruljothi, those who are not members of IMA, ask them to become members of IMA. You can always help them to become the members. And those who are IMA members can join the schemes also. Very beneficial schemes for their practice, protection, as well as for the family. Okay, thank you.
Thank you, sir. Thank you very much. Thank you, sir. Dhalapathy sir, thank you, sir.
Thank you, sir. Thank you. Thank you, Dhalapathy.
Thank you, sir.
Thank you. All the